All right, good afternoon, everyone. Thank you so much for joining us for this month's Teach Educational Round. Here with us today, we have Dr. Milan Khara and Alexandra Andric, who will be presenting on complex psychiatric illness and smoking cessation, psychosocial interventions, and pharmacotherapy. Before I hand it off to our presenters, I'm just going to go over a few brief housekeeping slides. If you're interested in receiving a letter of completion for today's Teach Educational Round, please make sure that you have registered for this webinar and completed the pre-learning assessment. You have signed in to view this webinar using your first and last name so we can track your participation. And finally, you've completed the post-learning assessment, which will be emailed to you by the end of tomorrow, and you will have 1 week to complete that. Please note that a copy of today's presentation slides will be sent along with the recording this afternoon as well. This webinar is being live tweeted on Twitter, and you can follow us at PSQuitSmoking and use the hashtag TeachWebinar to post or read questions. Here's a biography of our first presenter, Alexandra Andric. Alex is a registered nurse and has worked at the Center for Addiction and Mental Health since 2006. She has worked in a variety of mental health and addiction settings, such as the General Psychiatry Program and the Addiction Medicine Service. As an RN at the Nicotine Dependence Clinic, Alex monitors clients' responses to cessation medications, prescribes nicotine replacement therapy, counsels, and co-facilitates therapeutic groups. You can read more about her facilitation and teaching experience here. Here's a biography of our second presenter, Dr. Milan Khara. Dr. Khara is a UK-trained physician who joined Vancouver Coastal Health in 2003 after having previously worked as an addiction medicine consultant at the Centre for Addiction and Mental Health in Toronto. His current work primarily focuses on treating tobacco use disorder, but increasingly extends into other areas of tobacco control. He has been involved in training healthcare professionals and students throughout Canada to optimally treat tobacco use disorder, recently leading initiatives to combat the growing problem of e-cigarettes in high schools, and working in an advisory capacity with the Government of Nunavut to assist in their tobacco control initiatives. You can read more about his work here. Here's a list of her disclosures and his disclosures. And here's some more information on our disclosures. Please note that the content of Teach Educational Rounds are centered on evidence-based guidelines from the following sources. These materials, as well as the verbal presentation and any discussions, represent only general principles, and they do not represent the need for clinical assessment or treatment plans by healthcare professionals. Lastly, please feel welcome to use the chat feature during today's webinar to provide any feedback or post any questions. To use the chat feature, you can click on the speech bubble icon in the control panel, and please ensure that you select all participants to make sure that the panelists and hosts can read your questions. With that, I will leave it to our presenters to take it away. Thank you, everyone, and enjoy the webinar.
Hello, everyone. I'm Alex, and I'm going to begin our session today. I'd like to thank you all for taking time out of your day to be with us, and hopefully we'll be sharing some information that you will find very helpful in terms of helping the clients that you're working with. So our learning objectives today, we'll be discussing about modifying existing evidence-based psychosocial interventions for those diagnosed with concurrent disorders. We're going to be talking about adapting motivational interviewing for those diagnosed with concurrent disorders. And lastly, we'll be discussing the use of smoking cessation medication in those diagnosed with concurrent disorders to both maximize effectiveness and maintain safety. So the structure of today's session is I just wanted to let everybody know that we hope, or we would like you to save your questions, put them in the chat area, and we're going to address those at the end of our session. And also, any questions that we cannot get to today or cannot answer, we will provide information to you in the near future. So we really encourage you to ask all the questions that come to mind, and you will get that information at a future date. So let's now begin with an introduction to our case study. So Cassidy is a 45-year-old single Canadian woman supported by ODSP living in Toronto. Cassidy was diagnosed with schizophrenia at the age of 28. Cassidy informed her caseworker that in the past she heard voices that made derogatory remarks and told her to smoke. She also explained that this is why her previous medications were discontinued. In terms of supports, Cassidy mentioned that she really doesn't have a lot of friends, and they all smoke, the ones that she considers friends. She shared that she socializes with them at the clubhouse she attends weekly. Cassidy stated her closest friend is her sister, who has been recently diagnosed with cancer. Lastly, Cassidy shared her sister has begged her to quit smoking so that she can avoid her fate. Cassidy has been smoking for 33 years, starting at the age of 12. Cassidy smokes 25 cigarettes per day, has decided to come and speak with you because her sister has encouraged her to quit. Cassidy has come to her appointment with her case manager. So the summary of the first visit is mornings are the toughest for Cassidy. She smokes as soon as she wakes. There have been times when Cassidy has smoked butts off the streets. At the end of the month, this has occurred. And she also tends to smoke when she's bored. Cassidy has tried quitting multiple times, achieving 1-week periods of abstinence. Her sister's recent cancer diagnosis has triggered her to use alcohol again. Cassidy stated that she drank a lot of alcohol prior to her diagnosis, and alcohol often triggers her to smoke. In terms of smoking cessation medication, Cassidy has tried the nicotine patch and discontinued it because she could not afford it for more than a week. Cassidy stated that although she'd like to have more money and breathe more easily, she's unsure if she'll ever quit forever. So her current medications are clozapine or clozaril at 350 milligrams. She is consuming 2 standard drinks of alcohol per day, and she has let us know that she had issues with alcohol prior to her diagnosis. In terms of supports, she has a few supports, and those individuals smoke. And lastly, her sister was recently diagnosed with cancer. So before today's session, I'm hoping that you all received a little attachment that provided you with an assessment and treatment plan. And so I'm hoping as we go through today's session that you can populate these sections of this template and hopefully share your thoughts at the end of the session. And we will debrief with the larger group at the end of the session as well. So let's get into psychosocial interventions. So I know a lot of you are attending today's session because you realize the importance of helping clients diagnosed with concurrent disorders quit smoking. And what we find is that people who have been diagnosed with mental illness often smoke more heavily than the general population. They start at an earlier age. They usually smoke more cigarettes. They're more efficient in extracting nicotine from those cigarettes. They tend to have a higher dependence on nicotine, and they tend to have a shorter lifespan because smoking also allows for a lot of medical illness to show up: cardiovascular illness, respiratory diseases, and cancer, to name a few. And so I realize that all of you know the importance of helping our clients make a change in their tobacco use. So I'm hoping what we share today can provide you some additional information to the stuff that you may already know. And if you don't know some information, hopefully we'll tweak some interest to do some further investigations. Oh, sorry, I went the wrong way. Apologies. Okay, so what do we know about psychosocial interventions? So the CanAdapt guidelines let us know that we can use psychosocial interventions that are used with the general population, but they need to be adapted. And when we think about that process of adapting, it's really about who are the clients we are seeing and how can we make that information or those interventions applicable to them. And so that may be, for example, providing skill training. So for a lot of people, smoking is their go-to strategy when they're stressed, or it's a coping mechanism for them. Or maybe they have a lot of people who they are socializing with who are also smoking. So figuring out what kind of interventions can they use to help them to address their environmental, behavioral, and emotional triggers, and then using some problem-solving skills to help them achieve those goals. We also want to provide affirmation, support, and encouragement. A lot of people come in to get help with quit attempts, and they feel that they won't be able to do it this time around because they haven't been successful in the past. So we really want to let people know that the more kicks at the can you have, the more successes you can have. And bringing what worked for you in the past and thinking about what your barriers are now or in the past, that can help you achieve the goal that you would like to achieve. Offering support groups is very helpful because that also allows people to hear from others. You've got that same boat phenomena going on whereby, people can see people who are similar to them, how they have made some changes, get some ideas from others about possibilities on how to go about changing. And when we think about tailoring self-help materials, if we think about sometimes people who have been diagnosed with psychotic disorders, maybe they may have slower information processing, maybe it's harder to comprehend things. We don't want to bombard them with a ton of information at one time. We want to talk about one thing at a time. We also want to use different modes of presenting to make it more exciting and more engaging. So some practical tips is we want to provide a variety of ways to make a change in tobacco use, and I should even say commercial tobacco use, and flexibility. We want to be responsive to the needs of the clients we're working with. We want to provide choice and at the same time use our clinical judgment to, when we need to state our concerns or we need to maybe talk about some other possibilities, that we ask that permission, that we ask people their thoughts about the information we provide. Also, we want to look at other areas that smoking or tobacco use has an effect on. So we want to talk about, what is that person's experience of nicotine withdrawal? When they have, when their mental health is not at its optimal, what kinds of things trigger people to smoke? A lot of medications make people gain weight, and we know for some people quitting smoking can put that possibility of weight gain as well. So addressing that, does that person need a referral to the metabolic clinic? Can we discuss healthy eating habits? Can we discuss exercise? And so with all these things that I've mentioned, we also want to make sure that we put it in the client's court, so to speak. So we don't want to be dictating or telling people what to do. We want to be their guide and help them through our discussions maybe feel like that change is possible and keep that conversation about change going. So when we think about motivational interviewing, we need to do a bit of adaptations when we're working with people who have been diagnosed with concurrent disorders. And so we want to make sure that we're using our spirit and our OR skill. And we also know that when we put people in the driver's seat and they feel listened and heard and there's really a back and forth, a partnership there, and an acceptance there, and a drive by the clinician to really kind of elicit from clients their thoughts, their desires, how they may go about making a change. That's going to help with engagement and treatment adherence. Also, it's really important that we really address all the issues that are going on with a person. So if we think about the case study, you know, we know that Cassidy has been diagnosed with schizophrenia. So we want to make sure that we discuss, you know, how is her mood? Is she experiencing any side effects from her medication? Is she adhering to her medications? Does she still have some psychiatric symptoms? You know, and how is this related to other substance use? So we know in our case that Cassidy has started to begin to drink alcohol again because of her sister's recent diagnosis. And she has mentioned that as a trigger. So ensuring that, you know, she's safe in terms of the clozapine and the alcohol and the smoking. We also want to make sure that we talk about the relationship between mental health and substance use as well. Always leaving it in the court of the person to help, you know, have those discussions about how this change might happen and why it might be important to make these changes. So we want to incorporate that spirit, so that partnership, acceptance, compassion, eliciting from people what they're thinking about things. When we use open-ended questions, we want to make sure that we keep them very simple. We don't want to talk about 3 questions at the same time, because that can be confusing for people. We want to make our reflections very short and stick to one component at a time, so that we can, you know, allow that client to hear what we've said and process that information and respond to that information. We want to use affirmations, because we know affirmations are the biggest predictor of change and change talk. And affirmations also highlight the hard work that people have done, their determination, personality traits within them that could help them make this change. When we provide our summaries, we want to provide them often. And once again, we don't want to provide, you know, 8 pieces of summarized information, or like 8 things the person has shared, because once again, that may be hard for someone to take in and process. We always want to personalize the feedback that we provide, and we want to avoid focusing on the negative. We also want to explain, if we are using motivational interviewing, that it may be a different way of working than a person may be used to. And if there's any delusional content, we want to focus on the emotion that delusion is making, rather than the delusion itself. Also, we got to always remember that ambivalence is totally normal when people are considering making a change. So I want to share with all of you 2 studies that I looked at. The first study is the Let's Talk About Smoking, an interactive web-based intervention. And with this intervention, they found that interactive web-based interventions can be effective and have potential to be more effective. And if there's peer support there, it may enhance outcomes. What the researchers found was middle-aged individuals were more motivated to use smoking cessation treatment. So in this particular study with these young adults, at 14 weeks, and that was kind of the end of the study time, less than 15% had used additional cessation treatment out of those who quit. And that verifiable treatment was talking to a physician about smoking cessation and getting counseling on top of this interactive web intervention. Additionally, they found that 15% of participants had biologically verified abstinence at 14 weeks, and this was through these CO monitor. And what they found that an additional component was no one quit in the computerized National Cancer Institute education group or in the no intervention group. So 83.4% found the Let's Talk About Smoking web-based intervention useful and very good, while 71.4% found the NCI education good or very good. So let me just tell you a bit more about this study. So it was done in 2008, and it really came up because what has been found to be happening is a lot of mental health workers, it's quite erratic. Those individuals talking about smoking cessation or those individuals attempting to educate or enhance motivation in clients to change their tobacco use. And so what they did, the no intervention in this group was basically people had an assessment where they looked at nicotine dependence, eating and exercise habits, and psychiatric symptoms. Also, they were told that the researchers were interested in their smoking habits and cessation behaviors. And the group, actually, there was 81 English-speaking participants that were between the age of 18 and 30. And these individuals were able to give informed consent, and the average age was about 24. So the no intervention, as I said, was just basically an assessment. The computerized National Cancer Institute patient education was just a pamphlet that was modified into a computer format. The content was provided on the laptop with large black font and a white background with no distracting images. The information was placed in short paragraphs and bulleted sentences, and then participants could use an audio to kind of listen to the information rather than reading it. And then finally, the Let's Talk About Smoking web-based intervention. Basically what was in that intervention is they had used semi-structured interviews with 18 young adults who had been diagnosed with schizophrenia. And in this cohort of research participants, there were people who had been diagnosed with schizophrenia with mood and anxiety disorders. And so they had talked to these individuals who had been diagnosed with schizophrenia and kind of asked them what they would be interested being covered in this offering. And also they took into account any cognitive impairments, so, intention and info processing challenges, and they wanted to make it easy and engaging. And so the first module consisted of info and exercises, including a creation of personal pros and cons lists, and a quit story and videos to facilitate change. There was a young woman who was the host that helped people go through these modules, and she identified as a person who was a previous smoker and someone who had been diagnosed with a mental illness. The second module consisted of info and exercises, including a creation of a personal pros and cons list, and cessation treatment, as well as quit stories and videos to facilitate change. And the last module was basically about creating a personalized report highlighting desires to quit, treatment choices, and referral information was provided. The other study I want to let you know about very briefly was a study that went on in the UK. And basically in this study, people were recruited between October 2015 to December 2016. And these individuals, basically 59% were male. The average age was about 47 years old. These individuals had high nicotine dependence with an average smoking of 24 cigarettes per day. The other study I talked about, it was 14 cigarettes per day that the average was what people were smoking. And so what was interesting about this bespoke intervention is in this study, they used mental health professionals. And so they found that this was quite effective because these individuals were able to really understand the clients who have mental illness and concurrent disorders, and also they were open to have these discussions with their clients. So in this study, 14% quit at 6 months versus 6% at usual care. And then there was only a slight difference at that 12-month period. And we can see this in the general population as well, where it's really hard for clients to keep that quit going, to maintain that abstinence. In this study, nicotine patches were used the most, e-cigarettes were used, and very few were prescribed Varenicline. And at the time of this study, this was contraindicated for people who had been diagnosed with mental illness. And there's always been a problem with thoughts about Varenicline, and we know that Varenicline can be safely used with people who have been diagnosed with mental illness, clients who have been diagnosed with concurrent disorders, and Milan's going to talk about that very shortly. And what they found is with this bespoke intervention, that it increased the engagement and chances to quit. And a lot of people were given that opportunity to reduce towards a quit. They also found better short-term physical health results and a trend to decrease the number of cigarettes smoked per day at 6 months and an increased motivation at 12 months, which are both important factors, because even though, if someone is reducing their cigarette smoking, they're still being exposed to the problematic compounds in that cigarette smoke, and they may be smoking even more efficiently. There is still those behavioral changes that can kind of help people feel confident about continuing to make a change. And so I'm going to lastly say that the kinds of things that were adapted were, there were several assessments before setting a quit, so extended pre-quit sessions, offering of nicotine replacement therapy before setting a quit date. The practitioners really strove to understand the context of a person's mental illness and how smoking fit in that. They provided home visits, additional face-to-face support if there was an unsuccessful quit attempt or there was a relapse. They connected with the primary care physician and psychiatrist of these individuals, and they also themselves reviewed the antipsychotic medication, and they also let the providers know about that so that they would monitor that as well. CO was measured, barriers and solutions to those barriers were discussed. There were discussions about relapse prevention and coping skills, talking about how to look at triggers and ideas for those triggers, talking about how to do goal setting, how to use mental health resources, assessing past and current smoking behaviors, readiness to change, nicotine dependence, psychological and mental functioning. So there was a lot that these individuals did, and there was a lot of that really striving to help that person and have that individual care plan that would work for that individual. So I'm going to stop here, and I'm going to pass it off to Milan. Thank you.
Thank you, Alex. I'm hoping everyone is hearing me, so we'll do a very quick overview of medications in the context of people with mental illness and substance use disorder, then specifically in the context of Cassidy. What are the kinds of things that we might be able to use to maximize the likelihood of cessation? I'll start off with this statement from the Canada guidelines, which came out of CAMH a couple of years ago, and you can see the very clear definitive statement that these patients should be offered pharmacotherapy as a standard of care. This is a very similar statement to the one that we found in the American guideline from 2008, the guideline from the Department of Health and Human Services. And it's worth saying that I think this statement kind of flies a little bit in the face of a sort of historical hesitancy around the use of smoking cessation medications in these populations. And really today's takeaway message is that absolutely these patients should be offered smoking cessation medications. With very few caveats. I'm going to spend the next few minutes talking about those caveats, but these patients have an increased likelihood of cessation when they're offered these treatments, and it should really be an absolute standard of care. So that's my headline message. And moving on a little, let's just cover some of the caveats. First of all, just a slide to reflect on mode of action of the first-line smoking cessation pharmacotherapies. This is review for most of you, but here in this slide you see the alpha-4 beta-2 nicotinic acetylcholine receptor highlighted there, which is in the ventral tegmental area. We know that in those who smoke cigarettes, nicotine from the cigarette gets very quickly into that receptor, binds, and leads to a release of dopamine in the nucleus accumbens. We know that those who stop smoking will then consequently have a reduction in the stimulation of that receptor, and that will lead to a fall in dopamine levels in the nucleus accumbens. And that is the mechanism by which withdrawal is mediated. All of our smoking cessation medications essentially do their work at that receptor. So obviously with the NRT, that's pretty straightforward. Nicotine binds at the same receptor, of course, delivered a little differently than it would be delivered by cigarette smoke, but it lands in that same receptor, is a full agonist, and will hopefully minimize or maybe even eliminate the experience of withdrawal. Our second class of medication, Varenicline, is a partial agonist/antagonist at that receptor. It binds to the receptor, actually maintains those dopamine levels in the nucleus accumbens, and thereby reduces the experience of withdrawal. We also find that Varenicline blocks nicotine that tries to reach that receptor from the cigarette and makes cigarette smoking less reinforcing. And then our last class of medication, bupropion, probably actually does most of its work in the nucleus accumbens by blocking the reuptake of dopamine and thereby maintaining that dopamine tone and as a consequence reducing the experience of withdrawal. So that's where our medications work, primarily at that receptor. But what about these medications? In these populations, we know that typically these patients are more highly dependent and often have negative experiences with, for example, the patch. I'm sure many of you will have heard the refrain that these products just don't work for me, the patch just doesn't work for me. And the reason for that is that we are probably using them suboptimally. And if we're prepared to go off-label, if we're prepared to go to higher doses, if we're prepared to combine products, and if we're prepared to maybe use for longer than the products are actually recommended for as per label, then it is more likely that we will have success. And you will often hear the term off-label thrown around in the context of tobacco treatment. What does this mean? Exactly as I said, that we use them more flexibly, more aggressively, essentially. But it's also important to say that even though we're outside of the exact language in the label, we need to be using these medications in a way that is likely to be safe and based on some kind of scientific rationale. It's also the case that there is good evidence for most of these approaches, just not maybe the level of evidence that would change the exact wording on the label. So off-label is a term that's used across medicine actually, but is often used in the context of treating tobacco use disorder. The most common one that I think we see nowadays is the use of NRT in combination. So conceptually, when we think of pain management, we think of the long-acting opioid with short-acting morphine for breakthrough pain. It's a good way to think of the use of NRT in combination. The patch delivering nicotine at a flat dose over 24 hours, and a pocket full of gum or lozenge or inhaler for moments when the individual may crave, or may be in an environment where craving is likely to become problematic. It makes a lot of sense to pop a nicotine lozenge, get a bolus of nicotine to help them through that potentially tricky moment. There's good evidence that combination NRT is more efficacious than single agent NRT. In fact, it's probably about as efficacious as Varenicline. Varenicline and combination NRT being the two most efficacious approaches to pharmacotherapy. And this approach is now considered to be safe as per the FDA in 2013, and actually as per changing labels in Canada. We now actually see the gum and patch being delivered in a package together. And so we've moved from this approach being considered off-label to being somewhat more conventional. There are, of course, challenges around cost. If you live in a province where NRT is not covered, then having to buy two agents can be prohibitively expensive. But that doesn't alter the fact that this approach is certainly one that should be considered optimal, particularly in hard-to-treat populations. That FDA label change proposition also included the concepts that you see here on this slide. The top one is important, permitting the use of NRT while still smoking, or as Alex said, having pre-quit NRT. This, of course, means that there is the use of tobacco whilst using the patch. We now know this to be safe, and this opens the door for these reduced to quit kinds of approaches, which is very useful for getting those who are lacking in confidence or who are fearful around entering the smoking cessation process. The prospect of, here's your first patch, you're never going to smoke another cigarette again, stops many people from ever going through the cessation door. But if we can say, look, put your patch on, see if you're able to reduce a little bit with your next week, I think it's mental to be a way that is much less threatening and much less frightening for many of our less confident patients. And the last bullet point you see there, of course, is kind of obvious and barely needs explanation, but the idea that we need to treat people for 12 weeks, of course, is nonsensical. The only reason that NRT is recommended for 12 weeks is that's how the trials were done. But when we're treating a chronic addictive disorder that may have been around for 2 or 3 or 4 decades, we need to treat for as long as we need to treat for. And of course, the obvious analogy is methadone maintenance there. I won't say any more about that. We're now seeing some studies. This is a South African study which looked at a combination of Varenicline plus patch in comparison with Varenicline alone. And this is something that we've done a little bit in our setting. I'm sure it's been done in the nicotine dependence clinic at CAMH. In this study, over 400 patients. Follow-up was for 12 weeks of treatment plus 12 weeks of follow-up. And in the last 3 weeks of treatment, the continuous abstinence rates in the last 3 weeks of treatment, you can see 55.4% abstinence who were using Varenicline plus patch versus 40.9% who were abstinent using Varenicline alone. Pretty high numbers actually, but most importantly, you see an odds ratio of 1.85 for the combination approach. And most importantly, no increase in adverse events other than the rash, of course, that comes with the patch. So this is increasingly an approach that we're seeing in some of the more harder to treat populations. Again, costs can be prohibitive, but these are the kinds of things that I think if we're going to have success with these kinds of populations, we're going to have to really open our minds to. I'll skip a slide. I want to just say a few things about EAGLES. EAGLES is a study that many of you will be familiar with, and you will, I'm sure, recollect the history of how EAGLES came to be. As Alex said a little earlier, there was great suspicion around Varenicline in its early years, partly because there was a number of reported adverse events, a number of completed suicides that were allegedly caused by Varenicline. This led to great suspicion amongst people treating those with mental illness as to whether Varenicline in fact should be contraindicated. It was actually never truly contraindicated, but it was, but it became effectively practically contraindicated. And so this trial specifically tried to assess what the neuropsychiatric risk of Varenicline was in comparison with three other agents, bupropion, NRT patch, and placebo. But most importantly of all, these 8,000 subjects in this trial were actually divided in half, and one half were those who actually had mental illness. And this was unusual because most trials, of course, don't study that particular population. But obviously, if we're going to look at smoking cessation agents, and we know that at least half of those who smoke cigarettes have a history of mental illness in North America, this was an important consideration. So this half of the 8,000 patients were described as having stable mental illness. And without going a great deal into the details of the trial, the most important finding was that when we compared the four treatment conditions, Varenicline, bupropion, NRT, and placebo, there was actually no difference in neuropsychiatric adverse events, either in the psychiatric cohort or the non-psychiatric cohort. And this should give some significant degree of reassurance to those of us who use Varenicline in these populations. Now, there are caveats. There are questions that are not answered by this study, one of which is, what about Varenicline in somebody who is actively psychotic or who is suicidal, somebody who is not stable? This was looking at stable psychiatric populations. We'll probably never find the answer to those questions from within the context of a study, but this big trial certainly helps to give us a sense of the relative safety of all of these agents, and Varenicline in particular. Okay. Now, as you heard Alex describe at the beginning of the presentation, is taking clozapine. Populations, they often take other medications, and they often take antipsychotics. And the CYP1A2 issue is one that all of those who are involved in tobacco treatment in these populations should be familiar with. And what we mean by the CYP1A2 issue is that these drugs are often metabolized by the cytochrome P450 enzyme system in the liver. And of that system, one of those is the CYP1A2 system. And you can see which drugs are metabolized by CYP1A2 on the left of this slide. The older antipsychotics, chlorpromazine, haloperidol, and others, clozapine, olanzapine, and caffeine. And the way that tobacco smoke interacts with these drugs is that when those who are smoking are exposed to the polyaromatic hydrocarbons in cigarette smoke, this CYP1A2 enzyme system is induced. And what we mean by induced is made more efficient. So those who smoke will more efficiently metabolize the drugs that you see on the left compared to those who don't smoke. So clozapine levels are pushed down by cigarette smoking, particularly pushed down by heavy cigarette smoking. And in fact, we know that tobacco users who are on these medications are often on higher doses because of this effect. The important part of this story is that when cessation occurs, and in the times of smoke-free hospitals, this is happening quite commonly when people with chronic schizophrenia are admitted to a smoke-free hospital and as a consequence either quit smoking or have substantially reduced tobacco use. the induction effect of cigarette smoke on clozapine is lost. In other words, you now metabolize less efficiently, and blood levels of clozapine can potentially rise enough to become clinically significant and cause sedation, confusion, hypersalivation, lowering in blood pressure, seizure, etc. So we need to be cognizant of this. Some jurisdictions actually recommend reduction in dose. Others recommend clinical monitoring and reduction in dose if it becomes apparent that there is clozapine toxicity emerging. But certainly something we need to be aware of. The caffeine story is one that also should be foremost in the minds of those who are involved in cessation services. These populations, as we know, are often heavy caffeine consumers. Caffeine is metabolized by the same enzyme system. So when a heavy coffee drinker quits smoking, their caffeine levels may well rise to be close to double what they were before. And caffeine toxicity may emerge, and the agitation, the irritability that we may actually attribute to smoking cessation may simply be due to hypercaffeinism. And so recommending a reduction in coffee consumption by around 50% is a sensible precaution. Okay, so moving on, last couple of things to think about. I will say very little about electronic cigarettes. Of course, it's a webinar in and of itself. But clearly, as we move forward with this discussion, as we try to achieve some degree of consensus around the efficacy as a cessation device, around the efficacy of these devices in harm reduction, they may well have a role to play in these populations. And certainly in the setting that I work in a smoking cessation clinic, where we fail, in inverted commas, with our conventional approaches, and where we see people who have end organ damage, it seems absolutely illogical to not recommend switching to e-cigarettes as a very likely, very significantly less harmful device. And we certainly do that on occasion. So I'm going to finish there, and hopefully we've left a degree of time for questions, and I'll pass the ball back to Alex or to Sophie.
All right, thank you both so much. So I'm just going to go briefly through a bit of our kind of conclusions, and then we'll leave the rest of the time for questions, so then we can answer as many as we can. How does that sound? Good. All right. Perfect. So again, if anyone has any questions that you've not yet asked, please feel free to put them in the chat now. And again, thank you so much, Dr. Khara and Alex, for such an informative webinar. Thank you so much for everyone for attending. Again, this webinar has been recorded, and I will be distributing a link to the recording this afternoon with the slides, which you may feel free to share with your colleagues. Just a quick reminder that a link to the evaluation and post-learning assessment will be sent by email by the end of the day tomorrow, and you will have 1 week to complete that if you would like a letter of completion. As well, if you participated as a group, please email teach@camh.ca with a list of the names attended by 2 p.m. today. All right, so I'm just going to share the questions that we've received so far with the two of you.
So maybe I can read it out loud, and then myself, Milan and myself can kind of go for answering the question. So I read in a study that nicotine affects the brain in different areas of the brain for men and women. Does that mean the intervention approaches with men and women should be different? Thank you, Margaret, for that question. And I would be interested in you letting me know that's the name of that study, because I'd like to look into that. What I know, before I pass off to Milan, is that I know sometimes with women, just their menstrual cycles can affect kind of their ability to quit smoking, and maybe also PMS can have an effect. When I think about the interventions, one way I could think about it is, I'm not sure how to answer that, but I would also like to say that when we're working with people, we really want to make sure that the plan really fits with that individual person, that it addresses their concerns, their barriers, their, what they think may or may not work for them. If I'm thinking about trauma, if people have a history of trauma, it may be more helpful for people to have just a group for women and just a group for men. That's what I'd like to say before I pass it off to Milan.
Yeah, thanks, Alex. I mean, there certainly are differences, and I think there's a growing body of research that supports that. There are differences in responses to NRT as well. But clearly our standard interventions have not really yet evolved to reflect these differences. From a pharmacotherapy perspective, what I think all specialist settings are now doing is individualizing, and that should deal with some of those differences. But I think we've got a bit of a ways to go to really understand this issue. Can I grab one of these questions, Alex? I'm kind of conscious of time, and I'm seeing questions that I really want to try and respond to. The one that's come from not sure who, but from Jane, I would really like to answer. The question is, if Varenicline activates and blocks the receptor, how can adding NRT increase cessation efficacy, I guess is the question. So it's a really good question. And the question, I guess, to paraphrase it is, isn't it illogical to add NRT to Varenicline if the Varenicline is going to block the receptor, that antagonist effect of the Varenicline molecule? And that's absolutely how things started out when Varenicline arrived on the market. It didn't seem to make sense to add NRT because of that blocking effect. But clearly there is now emerging evidence that shows that you do increase cessation efficacy. So how do we square that? Well, my guess is that even though Varenicline might block the receptor blockade is probably not absolute. There is probably still some receptors that are not being satisfied, and so when you add NRT, you do get extra receptor blockade, and that's how that additive effect works. But certainly the practice of combining the two products is becoming more common. For a long time, when we used to put people on Varenicline who would do really well, have really reduced craving, and say that they've gone from to replace those 2 or 3 cigarettes. Now, whether those 2 or 3 cigarettes were being driven by behavioral associations or by inadequate blockade of the receptors, who knows? But it seems to be a logical thing to do to add short-acting NRT in that context. Alex, do you want to grab any questions? Anything that's appealing to you there? Okay, Alex seems to have zoned out there for a second.
Webinar on ABI, how to help patients with acquired brain injuries. I'm not sure when that is happening, but that is coming up soon, so maybe that would be helpful. There's a question about using Varenicline. Is there a guide about what dose of patch to use with Varenicline? In this situation, this person was on 84 milligrams of patch and went on Varenicline, wasn't sure how much patch should be used for clients with severe mental health issues. So I think that's, you've mentioned a lot of stuff, Milan, and I know at our clinic, oftentimes if people are chipping, like having these cigarettes here and there, they may use short-acting NRT. I've seen the physicians prescribe a patch, and I think it's once the person starts the Varenicline to assess and see what's going on, and that could kind of guide what NRT you would put on top of that, and you could use an algorithm for that. Would you agree with that, Milan, or do you want to add more to that?
Yeah, I mean, I think that the question is actually quite nuanced, and there's a very lengthy answer to it. But first of all, there is no max limit to patch dosage. I'll often hear people say, well, what's the maximum dose of patch you can use? And the answer is, well, what's the maximum number of cigarettes you can use? It's really, when we use NRT, what we should be doing is titrating to effect. And if that means getting to 3 or 4 patches, well, as long as there's no adverse events from that kind of dose, there's no reason why you shouldn't do that. That's going to be unusual. It's going to be rare, but you will see it from time to time in for example, people who smoke 3 packs a day or 4 packs a day. There are less and less people like that around now, just because of cost, I think in part. And to the question about combining NRT with Varenicline and what should max doses be, again, titrate to effect, titrate to comfort, and no adverse events. Varenicline titration, which is something that we see being used a little bit, tends to be limited by nausea. So it's really hard to get much above standard dose. 1 milligram BID is standard dose. I've got some patients that double that, but typically nausea will be the limiting factor. Can I answer another question, Alex? I saw one about lifelong use of Varenicline. It's a really good question, and Varenicline is recommended for 12 weeks. You can use it for an extra 12 weeks. In BC, we get coverage for 24 weeks. But to come back to my initial point, we should use these medications for as long as they're needed for. There are safety studies that suggest that Varenicline for a year, it has no adverse effects. If your patient needs to take Varenicline for a year or 2 or 5 or 20, it's got to be better than smoking, and there's no reason why it would be expected to be harmful. So we should treat for as long as we need to treat for.
And unfortunately, in Ontario, it's still just 12 weeks, which is too bad. Okay, so I'm just looking down more here on the side here. There's a question about with the are there any geriatric considerations with using Varenicline?
Yeah, good question. You certainly can dose reduce if you think that somebody is still reasonably efficacious. You particularly do that in the context of renal impairment. And so if you are treating somebody with impaired renal function, you may well dose reduce. And certainly in the elderly, you may think about that if there is frailty and suggestion of renal failure. Varenicline is almost completely eliminated by the kidneys. It doesn't go through the liver. And so if there is impaired renal function, then you would want to reduce. There's a question there which I just want to quickly get in. Can a family doctor prescribe Varenicline itself to people with mental health issues? Absolutely. Any physician can prescribe Varenicline. There are still anxieties about Varenicline because of the early years, but hopefully some of that perspective is shifting. It should be the case that for anybody on any cessation medication that we are actually monitoring, and that would apply to Varenicline also.
So I noticed I've got 12:59 on my computer here, so I want to let everybody know that we are going to look at the rest of these questions that have been put forward, and that you will, the whole group will receive some answers to those questions. And I really encourage people to think about Cassidy and fill out the assessment and treatment plan. And if you have any questions about that you send those questions. And we we appreciate you attending our webinar today, and I hope that all of you found some good information to help you help our clients reach their goals. So thank you so much.
Yes, thank you again, both of you for presenting and everyone for attending today. A really informative webinar. It was lovely. Just as a quick reminder, our next webinar will be on mindfulness and meditation, which will be presented by Stephanie Kirsta and Carolyn Platter. This will take place November 25th from 12 to 1, and you can look forward to registration for that soon. As well, if you missed a portion of today's webinar or you're interested in viewing it again, or you would like to view our previous webinars, an archive list can be found on our website, which is available here. Thank you so much, everyone, and enjoy the rest of your week. And thank you again to our presenters. Have a great rest of your day.
Thank you so much.